Hello, my name is Ehrin Armstrong. I'm an interventional cardiologist at Adventist Health St. Helena. And today I'll be sharing some cases of using intravascular lithotripsy for treating patients with critical limb ischemia. The second case I'd like to share is a 75-year-old man with a non-healing left second, third, and fourth digital ulcers. The patient was on hemodialysis and had a history of chronic kidney disease. He had a known left popliteal artery occlusion and actually had had two prior unsuccessful attempts by another physician to cross that occlusion. He was therefore referred to me for complex intervention for his critical limb ischemia, and this was really a last-ditch limb salvage attempt with regards to this patient being on hemodialysis, and if we weren't successful, he was looking at a high possibility of a below-knee amputation. In this case, in order to maximize the wire control and the ability to cross the occlusion, I obtained antegrade left common femoral artery access so that I'd have the maximal pushability and options with regards to re-entry if necessary. You can see here in the baseline angiogram that the patient had a popliteal occlusion in the P3 segment, right at and a little below the knee joint. The runoff was single vessel perineal runoff to the level of the foot. You can see that the perineal provides some cross collaterals to the medial and lateral communicating arteries at the level of the ankle. In this case, I was actually able to cross the lesion successfully with an 018 Astato 30 CTO wire. You can see here on the fluoro capture here that I had a support catheter. I was able to dig into this calcified cap and then able to navigate successfully into the true lumen. If I had not been successful with that, I may have had to obtain retrograde perineal access in order to cross the occlusion. But since I was able to cross antegrade, I was then able to switch that Astato wire for a supportive 014 Ironman wire. I then advanced a 5 by 60 millimeter IVL balloon at 4 atmospheres to the site of the occlusion. And you can appreciate here that when I first inflated the IVL balloon and started delivering pulses, that there was initially a pretty significant waste somewhere around the range of 22 to 23 here, shown on this marker tape. In order to optimize a potential standalone balloon angioplasty result, I delivered 120 cycles of IVL to this lesion with a goal of getting a good quality 2 minutes of IVL pulses with concomitant balloon angioplasty to try to really optimize the outcomes of treating this severe lesion. This is just a still image showing what that IVL balloon looked like initially after the first inflation and prior to delivery of the shockwave pulses. And afterwards, you can see after 2 minutes of those pulses, there was minimal residual stenosis. There was a non-flow limiting dissection that's probably a grade B dissection across that popliteal segment. Based on these findings, I then proceeded with drug-coated balloon angioplasty across this long segment popliteal disease. I inflated a 5 by 150 millimeter drug-coated balloon at 8 atmospheres for 3 minutes. And you can see here that the final angiographic result was really quite excellent. There's good expansion of the lumen across the entire area of the stenosis. There's preserved collateralization across the popliteal. There's probably a grade A dissection in the mid to distal segment, right where that CTO cap was. But given the fact that I had performed IVL with good vessel expansion and minimal dissection, followed by drug-coated balloon angioplasty, I was confident that this would remain patent.